Good afternoon. And today we have a very special guest. We have a pleasure of interviewing Dr. Bill Hangs. Good afternoon, doctor.
Hello, nice to be here, Maria. Thank you for having me.
And thank you very much to our audience. If you someone who have a bad sleep or sleep next to the snoring partner, this program is for you. You would understand routes to roots. If you are a medical professional who, just like us, trying to put all puzzles together to find the answer why sleep apnea is so widespread in the present time, we will also uncover this topic. And I want to tell my personal story, how I knew about Dr. Hanks. So he's very famous in our community of people who are treating the airway or trying to find a cure for airway problems, because he's practicing expensive, not expensive like expensive, but expensive like very precious for your health, orthodontics. And also, he's really big opponent of retraction orthodontics, when, and a lot of orthodontists move everything backwards towards the airway, and eventually airway gets collapsed. And I always want to interview him, and I met him this year on a PANI conference, and of course, I want to bring them in front of my audience. And now, a little story about Dr. Bill Hangs. He's actually an orthodontist. I interview a lot of people who are doing orthodontic treatment, but they're general dentists. But he's orthodontist who had this training and who realized after practicing what he's actually changing people's faces, maybe not so much to the best. He's following traditional ways, like a lot of orthodontists still doing today. He noticed not a positive result. And he's going to share the story how his aha moment happened. And then the beautiful thing, what I always like to bring, he realized, he analyzed his results, and he changed the way he practiced. He took a lot of continuing education courses, and I kind of, went 180 degrees and start expanding the jaws, creating more space for the tongue, practicing the principles we constantly talk about on our channel. So I want to mention also that he was a dentist in Air Force, United States Air Force. That's a nice, part of your bio I want to mention. Please share with us kind of your story in that aha moment. What happened? Why,
Well, I was trained in orthodontics at the University of Minnesota, and I was asked to stay and teach, which I did. Then I decided that I didn't really want academia, and I wanted to get away from the cities, and I moved to Vermont to practice. I thought I knew everything because I graduated at the top of my class, and I did exactly what I was taught, taking out teeth more than half the time. After a few years, I began to look at the faces and realize that they were not that great. And there were people in the profession saying that indeed orthodontists were messing faces up by what they did and causing TMJ problems. I decided to I had a lunch one day with the general dentist who was my best friend, and he said to me, I'm doing continuing education, and I've met orthodontists who don't take out teeth as often as you do and who treat earlier. Why do you do what you do? It was one of the most embarrassing moments in my entire life. But I had already begun to question what I'd learned. And I knew then, after the adrenaline shot through my body, that I had to do continuing education. So within a matter of a few weeks, I flew to San Francisco to take a course, and one course after another and another. Practicing in a small town in Vermont, if I was trying new things, and if new things were going to work, that would be great. If they didn't, then my practice would be over, because what you do in a small town gets home before you arrive at the end of the day. And you're either going to do well or poorly based on your reputation. The good news is what the new things were doing very well. And I got patients from all over the state. The general dentist loved what I was doing versus what the other orthodontists were doing. And my practice grew and flourished. Over time, it was a very uncomfortable time because I still wasn't I didn't have a scientific basis behind what I was learning. I was just doing new things that other people were talking about. They said they were okay. But over the years, I met other people, including John Mew, who finally put it together with a cohesive philosophy of why the face falls back and why malocclusions develop in the first place. And it really is so simple. The face falls back, the front teeth fall back, the lower jaw falls back in every case, whether it's a class 1, class 2, or class 3. And the fact is, you need to change that. And it's because of poor rest oral posture that the face falls back anyway. And so over the years, I've changed my practice completely. I then left Vermont because I didn't want to retire. I was really excited and I wanted to be in a better position to practice in a more affluent area where what I was doing would be more appreciated. In 1996, I moved to California and set up a practice there. I ended up having patients, I did tons of continuing education. I learned a lot on my own, started innovating new things, and I ended up with people from more than 30 states and several foreign countries coming to my practice because what I was doing was totally unique.
Yeah.
I don't tend to have all the answers, but I'm here to share what I've learned in the process.
I'm wondering, you did training with John Mew, who is very influential person of our time. What exactly is orthotropics, what he's talking about?
Orthotropics it's a term that John coined describing what he did and why he did it. Basically, it recognizes that the very first thing to happen in every malocclusion is that the upper teeth start to fall back and the lower jaw as well. Both jaws are falling back in space. So orthotropics is something that's done on growing children. I think this is very important. Generally under age 10, it's most ideal. And from my perspective, ideally, it should even be done in the primary dentition prior to age 6. But you develop the upper jaw forward and then the lower jaw forward. And this is terribly important because what you're really dealing with right now in the whole sleep apnea pandemic thing is that people are talking about lateral expansion, which is lovely, but it's not the issue. It's part of the problem. You cannot expand your way out of an anterior-posterior problem. Malocclusion and sleep apnea are anterior-posterior problems. If our faces were forward where our ancestors were, we wouldn't have the problem. That's a quote from a very well-known Harvard-trained sleep physician by the name of Dr. John Remmers.
Yeah, we know Dr. John Remmers. You come up with a beautiful term, and it sounds to me so poetic, and it's called extraction, retraction, regret syndrome. What exactly this poetic term means?
Well, it's interesting. I define it as a constellation of aesthetic, functional, and emotional signs and symptoms brought on by orthodontic retraction, all of which are preventable because retraction is preventable. The sad part is that most orthodontists retract without even knowing it. There are things that they do unknowingly that retract. It took me many years to come up with this. I started reopening extraction spaces for people. The first person was in September of 1989. And it was a new thing for me. I had no idea if it was going to work, but I had a desperate patient that her life was miserable. She had headaches, and she was 27 years of age. She'd had headaches since her orthodontic retractive treatment had occurred, and she was desperate. She had pain basically all the time. And I began reopening for her. I promised her nothing. I got rid of her headache symptoms, and they've been gone ever since. But that changed my life because I then did it for other people. I did it in my own mouth. I reversed a retractive treatment that I'd had when I was 11 and 12. And that became a huge part of my practice. But it wasn't until probably 15 years ago now that I really recognized this was a syndrome. A very real syndrome, a constellation of things going on all the time. Not to say that everyone who has a teeth extracted is going to suffer, but how do you know if they are or are not going to? You don't know. And I have people from all over the world contact me, often on the internet, basically identifying themselves as, quote, a poster child for ERRS.
But can you talk about emotional part? Because ERRS, I have a sleep practice. So this
Right.
retraction syndrome put a lot of bread on my table. Maybe I do the treatment not in ideal way for you, but whatever my patients accept. But
Right.
what I noticed, a lot of people have a bouquet. They have acid reflux, they have asthma very often, arthritis, high blood pressure, and sleep apnea, and TMJ.
They they have a long laundry list of symptoms that go together. Those are functional symptoms. The one you ask about is the emotional aspect. The emotional aspect comes when someone realizes, oh, gee, my face isn't as nice as it used to be. My face is caved in, and they hate that. But more than anything, when they're seeking answers and they maybe have been to many different states and found doctors that are well-meaning but aren't helping them, and they spent tens of thousands, if not hundreds of thousands of dollars looking for answers. Over the years, the emotional aspect of that starts to rule their life, and they end up becoming their pain. They become their pain. And those people who are treating in this arena need to understand that. And if if you're a doctor and you don't understand the triad, the aesthetic, the functional, and the emotional aspect, you are going to have some very bad, unhappy people. And there are some people that you basically should not treat because of that very issue. Some people are so in such bad shape that they're never going to be helped, and that's very sad. I've met these people. Sadly, I've treated some and regretted treating them.
Yeah, we all did. We all want to help. We want to
Exactly.
feel that satisfaction from helping somebody. But
Exactly.
I want to ask you very specific question about what research support the idea what orthodontic treatment can enlarge the airway and improve breathing.
First of all, what you have to understand is that there's a white paper out there that basically says there's no relationship. But if you truly understand the white paper, you realize what was behind it, who was behind it, who wrote it, who were the authors were. And I'm not going to get into that.
No.
That's the bottom line. Okay, the resource that tells you, okay, great. You asked me, we did in the year 2000, I recognized that the orthotropics patients that I was treating, I was getting some rather dramatic improvements in the airway. And I then did a study on my consecutively treated patients. I didn't do the study. I had someone else do it and look at all the airways on all my patients, those who cooperated and those who didn't. We got a dramatic improvement in the airway. 31% at the dorsum of the palate, 23% behind the tongue, and even 9% in the laryngopharynx. This was published in the Journal of Craniomandibular Practice in April of 2007. I'm pretty sure I was right on that date. It's in the refereed literature, it's there. Now, the important part about this is we never promise anyone anything. We never promise resolution of even one symptom to one patient. Never once in my life did I ever do that. Having said that, I didn't enter into treatment with people unless I had a good idea that I was going to be helping them. There's so many factors that can help or hinder with these issues that just by changing the shape and the morphology doesn't necessarily promise resolution of symptoms. But there are definitely issues that support that you can improve the airway. There are also articles in the refereed literature talking about retraction that decrease the airway. And any person with a mobile device could find those. Unfortunately, none of those were cited in the reference that we made earlier. They're out there. A 10-year-old kid with a mobile device and knowledge of the internet could find these articles.
No, actually, those articles I found exactly 2 days ago before our conversation. But now I want to ask you the question. A lot of professionals talk about airway size. We just talk about airway
Right.
size. But some professionals talk about tone of the airway. And I'm doing oral appliance therapy in my functional therapy. I try to improve tone of the airway, even with the moving lower jaw forward or with making my patients to do the exercise. Tell me, what what has more significant impact on sleep apnea, size of the airway or tone of the airway?
That's a great question, and I don't know the answer, and I don't think that anyone knows the answer. What my real answer to you is that if you were choosing an airway, you'd always choose the biggest one. That doesn't mean that the biggest airway is going to make it so that you won't have apnea. You can have a monster airway and still have apnea. 20 millimeters in the anterior posterior plane of space is huge. And I've seen people with a 20 millimeter airway and they have apnea because they have very poor muscle tone. And you can have a tiny little airway that does not collapse and they don't have sleep apnea. Again, the muscle tone in a case like that is probably much better. And there are other factors that are involved here that we don't even talk about, like vitamin D levels, and I happen to believe there are probably other things that we haven't even identified. We're in our infancy understanding these issues right now, and so for the practitioner, I think you have to look at the size, which is something we can alter, maybe most of the time. And again, you can't expand your way out of an anterior posterior problem. You have to work in the AP plane if you're going to really help these people. But also you have to work on the muscle tone, which means myofunctional therapy and breathing exercises are incredibly important.
Yeah, thank you very much. And now I want to ask you the last question. How do you approach treatment of sleep apnea with orthodontics? What role does jaw extension or forward movement play in that process? I mean, specific thing. Do you believe what changing for adults jaw
okay
size?
That's a very challenging question to answer quickly. It's very complex, and what you have, this is a disclaimer, what I see happening in the profession is it's a knee-jerk reaction, and it's expand, but that means lateral expansion. So the point is we need ways to develop things forward and expand laterally. Look at the tongue box. The tongue is here and it lives between the upper and lower teeth. So anything you can do to increase the size of the tongue box, both laterally, but in the forward anterior posterior plane of space, that's what really matters more than in the lateral. The point is you must get tons of space for the tongue. And even with that, sometimes you're not going to be successful. That may involve orthodontic means, it may involve surgical means. And you have to understand, even with the most sophisticated surgery done, and I've done literally hundreds and hundreds of surgical cases over my 50-year career, even with that, sometimes the face is so far back that you're not going to get a complete resolution. It's a sad thing. The most important thing is to make a child become a nasal breather as soon in their life as possible so their face does not fall back.
No, thank you very much, Dr. Hangs, and you share so much wisdom. And I highly recommend people who want to learn from you, they have to go on your website, ortho2health.com, www.ortho2health.com. We're going to put the link underneath the interview and learn so much from you. And I think you kind of set the future of this profession, gonna make a health of a lot of patients better.
It's been my pleasure. I've enjoyed being an orthodontist. I've enjoyed dentistry. It was a gift that I was given, and my feeling is I need to give back. We all need to give back, and we rest on the shoulders of those who came before us. And I have had a number of very, very important mentors, and I acknowledge all of them. And I hope that people smarter than I am come along and take this and make something better out of it, so that we don't end up with people having apnea the way they do now.
And extraction, retraction, regret syndrome as well. But I want to mention the book you mentioned to me before the interview. It's a great book. It's so much ahead of the time, by George Catlin. Book, Shut Your Mouth and Save Your Life. You mentioned it, and I think it's a great book. I agree with you 100%.
Yeah.
It would be really useful for parents and medical practitioners to read that book, The Wisdom which was developed 200 years ago.
Yep.
Or maybe even more, because he learned it from American Indians.
Exactly. When you really explore, The ancient Chinese were even talking about this in Chinese medicine. They recognized that someone with a retruded jaw does not live into old age. My feeling is that they knew more than 1,000 years ago, long before we ever came up with this diagnosis of obstructive sleep apnea, the people in the medical community, whatever kind of medicine that was, they really had the knowledge. So really not dealing with anything new. We just have new ways to describe it.
Yeah, like something new is very well forgotten old. I don't know that we have that expression in Russian.
Yeah,
So it all goes in spiral. We just have to get
exactly.
to that. Thank you very much. And we're looking forward to learn from you.
Well, thank you very much, Maria. I appreciate the opportunity.